We are good to go, ma'am.
Yeah. Good evening, everyone. I welcome you all to the experts appraisal on emergency medicine. This is a pioneering initiative of Yashoda Hospitals. Every Friday, we gather virtually to delve into the latest advancements of emergency medicine and best practices in emergency medicine. We get speakers from across the world, both national and internationally, to delve into the knowledge that is shared by all the experts. So this is a platform created to share the best knowledge and best practices across the globe and foster collaborations in the ever-changing field of emergency medicine. Behavioral emergencies is a complex subject when it comes to dealing in the emergency room. Today, behavioral emergencies in emergency department is brought to us by Dr. Sapna Gupta. She is an associate professor at NH Medical College, Gujarat, and she will be sharing her knowledge and expertise in this topic. Over to you, Dr. Sapna Gupta, for your enlightening talk today.
Yeah, thank you, Dr. Sowjanya. It's a privilege to be associated with you all. Thanks to you and Dr. Srinath sir. And this is a topic I was given a choice of topic, and I have chosen this specially because the rising trends of behavioral emergencies in our setup, or I would say globally after COVID, especially. So coming to my presentation, can you all see my screen? So that is typical. This one is like a typical scenario. A 45-year-old man with a history of schizophrenia or any chronic background illness, psychiatric illness, who has been stable on the medication since past many years. Now, one fine day, his neighbor notices that he is acting unusual to his normal behavior, and he calls emergency services. At the room, this person is quite violent, agitated. He is speaking incoherently and appears to be hallucinating. Medical team assumes that this is a deterioration or relapse of his baseline psychiatric disease, and that's related to his prior diagnosis of schizophrenia, and start him on the medication to calm him down, like the usual agitated patient with this background presenting to us. And if you can see the monitor, patient has tachycardia and tachypnea, plus he is not allowing to put the monitor on him also. So why there is so much hype about mental health? Because if we look at the global scenarios, there are too many global emergencies, pandemics, conflicting or non-conflicting. Some are natural calamities. Some are riots, like they are conflicting emergency riots or terrorism, all this like COVID pandemic that affected the whole world at a time. So this, when there is so much uncertainty of life, and a mass population is affected with the uncertainty and survival crisis. At this time, mental health should be a component of National Disaster Preparedness Plan, as per WHO and other supporting organizations, that adequate psychological support should be provided to the people. Now coming to the emergency room, the usual emergency room is full of patients, all sort of emergencies. Here, these patients, they need help. They may need help once in few months, or they may need help 5 times in a day. There are patients who will come in the morning, in the afternoon, in the evening as well. So many frequent ER visits. They take burden on the resources, because there will be uncooperative behavior with the medical people. Substance abuse is on very high rise, and Plus, there is a complex presentation, medical presentation, which leads to challenges in the diagnosis and management. So, if we look at the statistic, this is statistics of Gujarat in pre-COVID era. This article was of 2019, I guess, 35% rise, and now it is 2024. And there is we all are now not unknown to the substance abuse emergencies, addictions, domestic abuse, violence, that everything has become a usual occurrence in our emergency scenarios also. So, defining behavioral emergency, it is defined as a situation in which client presents with the imminent risk of behaving in a way that could result in a serious harm or death to self or others. This requires a very careful evaluation, and once the evaluation uncovers an imminent risk, therapists have to respond very quickly to prevent harm to the patient himself and to his environment. It can be property or it can be people surrounding him. So, the management, as the usual ER patient will walk in, we will triage, we will do assess the patient, and we will dispose the patient. But this patient, at each step, we need to have particular precautions that once the patient walk in into the ED, we need to have some sort of medical legal procedure. We have to screen for the weapons or illegal items patient might have. And we have to triage the patient in such a way that it should not disturb the other patients, and patients at the same time, patient is very well taken care of and monitored. Continuous monitoring, assessment, which is a complex procedure. I'll be coming to it on that. And then disposition, again, it is very careful disposition, making it damn sure that patient has no medical condition. If he doesn't have any medical emergency, and he is disposed to proper mental health care facility or in the care of a rehabilitation center or his relative where he can be observed. So, looking to this study, this study was done over the period of 5 years on more than 400 patients, and the findings are really striking. And somewhere we can relate to this. We know this, that there is a lower quality of healthcare in the treatment of these patients' somatic disorders. They are vulnerable with limited ability to information. They are unable to express the physical symptoms or to separate them, physical organic symptoms from the functional symptoms. Usually they are underdiagnosed and undertreated for the somatic condition or organic conditions. And the psychotropic drugs, so many psychotropic drugs have neurotherapeutic index, and they have multiple drug to drug reactions. Simple antibiotics can cause drug to drug reaction in this patient, and which can lead them into emergency room, which might not be cause of busy illness. To all these common genetic risk factors are same for both group of patient, whether he is a somatic disorder or it is a psychiatric disorder. So, idea is that we accept that these scenarios, we caretakers in their mind need to normalize this emergency, remove bias and stigma of that, to give the best patient care, because it is a right of human to be fairly treated, and we all aim at it. But sometimes there are risk factors, so many risk factors, like they might be having conflicting background, social lack of social support. There are substance abuse rising, which again complicates the effect of complicate the symptoms. So this episodes will heighten the risk of further psychiatric conditions. So causes can be psychiatric disorder, again substance abuse. Certain, like in elderly, a single episode of fever can trigger delirium or ICU psychosis. In ICUs, we very commonly see that within 24 hours, patient may become so some ICU psychosis features. We are used to diagnose it, but we are not able to it may become challenging when patient already on the psychotropic drugs. There are environment factor, there are major psychological, major social traumas or familial traumas which can trigger these emergencies. Common medication, we all know that steroid and fluoroquine.
Just give us a minute. There was some disconnection from Dr. Sapna. Welcome back.
Okay, yeah, I have connected again. I'm sorry, I don't know, this technical issue should be from my side only, but this is like what technology does the most. When we need it, it fails us. Then there are drugs of abuse, obviously cocaine, they also cause hallucination. All drugs are.
Your
Can
screen
you
is
listen
not
to
seen.
me?
We can hear you, but your screen is not
Not
seen.
seen? Yeah, my screen share is loading. It is saying that it is loading.
Yes.
I will try to share again. Can you see it now? So these are the MDMA, marijuana, all. Can you see my screen now?
Yes, we can see your screen.
Okay, so this all stimulant drugs can also lead to complex symptoms, which can look like toxicromy, which may look like poisoning, but which may look like a depression. A patient may come in the last stage when patient will in coma. Commonly, they will lead to respiratory depression and life-threatening emergency. They can present at seizures also. So agitation, violent outbursts, panic attacks, or disorientation with the surroundings. We all know that these are symptoms of so many common neurological condition also. But the only problem is when there comes a background history, as we take sample history in all patients, and with the light of background history, everything becomes hazy and the picture becomes very complex. So the spectrum can be starting from the suicidal risk, violent behavior, excited delirium syndrome, to the psychological crisis, which can be severe depression to severe violent, aggressive violent behavior. Usually anxiety can be the trigger of this. Patient might give a history of a recent psychological trauma or any recent problem which triggered this event. They may present with extreme agent where extreme agitation where patient safety becomes a concern. You may need to use the extreme measure to confine patient to the bed only when they present, even before diagnosing them, even before knowing anything. To prevent the threat to the environment, you might have to do that. So uh, when this patient has got some criteria which tells you that this patient now needs very crucial attention, when they have unstable hemodynamics, hypotension, bradycardia, they are severely hypothermic. Hypothermia is more common in these patients, and if they had posed the risk of suicidal attempt, they are losing body weight, get anorexic, and when there is a lack of insight and lack of motivation to recover, with a background coexisting comorbid condition, chronic medical condition like diabetic hypertension, plus severe family dysfunction, all this leads to this patient to come into priority attention. So we have to commonly we identify altered mental status, AEIO tip in which we include alcohol, endocrine disorders, infection. These are the differential diagnosis, overdose of drug. Then U stands for uremia, T for trauma, or I would say abuse or battered syndrome. They not uncommon in our country also now. Insulin, psychiatric condition, and then shock or stroke or space occupying lesion. Diabetic patient can go on the either side of spectrum, and they can present as behavioral emergency. They can go into this patient may exhibit typical abnormal altered mental status, and that may resemble intoxication. And the usual diagnosis, the first diagnosis by default assumed by medical practitioner is some sort of overdose or self-medication or self-overdosing. So psychotropic psychiatric condition can cause unintended alteration, and they lead to acute medical condition. So physical examination main features will be abnormal vital signs. There can be fluctuating level of consciousness, and there we have to be very carefully looking for the focal neurological signs. This focal neurological signs can give us clue to, as we know, that frontal infarct can also cause hallucination. A schizophrenic patient can also have hallucinations. So we have to give a very wide of differential diagnosis in this patient so that we don't miss anything else. When this patient comes in the ER, we need to have a very calm and direct, or I say thorough professionalization and professionalism and non-judging, non-biased environment is needed. It is a demand of an hour to not to isolate or tag these patients, to give excellent patient care and not missing any salvageable medical condition, which can be very simple, as simple as a stroke, which can be treated in time, and we can give a better life to these patients. Okay, so part of safety precaution, one should know the exist. One has to maintain the safe distance. We have to establish rapport, especially because in this scenario, the history may be very confusing. There can be medical legal background. Then we need to take a family in confidence. If patient himself is not cooperating, then we need effective questioning technique with the lead question, where we I would say we don't want to know the triggers, or I mean the background or the root cause. That's not our job. Our job is to understand whether this problem is at present is organic or not. So we may not require the complete social background or complete. As such, we as an emergency physician, we are focused in our history, but here the symptoms, we have to be sure that they lead us to the range of diagnosis. Okay, so again repeating, we have to do weapon scan, we have to have a calm approach. Then medical assessment again starts with the supplementation or priorities, airway assessment, then supplementation of oxygen, stabilization of vital sign, and blood glucose. Because majority of psychiatric illness, when they decompose, they lead to anorexia, and anorexia is a severe threat. And hypoglycemia can be the very commonest thing which can lead to altered mental status. So at a time, we need to sedate this patient, where we can use benzodiazepine in limited cases. One may use ketamine also under the supervision, and the restraint is a last resource which may need to be used if your patient is a showing violent behavior. There are some principle of restraint that they should be It should be front with face up. It should not be face down. Patient should well, and he should to breathe. It should, the restriction should not be like to totally immobilize the patient, but it should be like that we should be able to monitor him, and we can see the movement of, there are this type of CCTV and ambulatory monitors are been in fashion. Bandaging also is, ball bandaging is preferred rather than immobilizing the major, restraining the major joints, which can lead to further complication. Like if so many times it happens that when patient is out, he is restrained from and after 2 days, when you notice he has calmed down and there is a weakness on one side, he couldn't notice it because the hand was tied. So this is a common finding in the ICUs. So we need to identify this objectively. We need to understand the trigger factors, and the response protocols should be very clear for all the institutes. The observations can be from the family member, can be if you are aware of the patient's treating physician, you can identify the difference. Trigger factors can be narrated by the patient himself, or it can be there can be analysis of in past medical record. So this situation needs a very keen attention from the healthcare professional. So to minimize the assessment failure, we need a comprehensive history. We have to incorporate the collateral information, like patient staying alone, seen by relatives at the what last time he was seen. We have to identify abnormal vital signs, and we have to evaluate life threats. That if we dispose this patient from the ER for the simple symptoms, mild delirium, and we discharge him, then is he prone to commit any suicidal attempt after the discharge? Then these patients are to be handled to the healthcare facility of the relatives. So for improving medical clearance, we need to cultivate an environment where we have to adhere to the best practices, which will clearly identify the patient's need, and it should improve the trust of people in care. Because I would say that a patient coming to the emergency room for as such, institutes have a protocol to be a chest patient. Suppose I would always tell my resident that if he complains of chest pain 5 times in a day, you take ECG 5 times a day. It's not wrong to take 5 ECGs at a time. Being wrong all 5 times, it is okay. But if sixth time you are, if once in lifetime also, if you are missing an MI, patient complaining of chest pain, it very seriously affects our confidence, also the patients and relatives trust in the healthcare. So this patient's transport policies are being defined by the various mental health care guidelines, and they tell you that you need to transport to recovery response system. You need to consider transport of the patient who are emaciated with these conditions, where there are crime involved, and you need to confine this patient to the areas. You do not transfer them to recovery response center if there is a drug overdose, intoxications, unstable vitals, or patient being pregnant, or there is recent history of seizure, or a history of use of anticoagulants, and with history of background trauma of any sort. We need to document each and everything at the time of transfer of this patient. So legal and ethical consideration are a must. Confidentiality is must in these cases, and it is a duty of a doctor to protect the privacy of this patient, and protect them from the harm. So if I tell you the detailed diagnosis of the first slide, which a 45 years old male presented with hallucination. This patient had this CT scan on further investigation. As you all can see, it was a frontal infarct, and that lead to presentation to ER. So my conclusion, coming to the conclusions, we need to identify the early signs of crisis, need to respond immediately, refer to the appropriate facility immediately, and each time when a violent patient or a patient who are threatening us to utilize our resources properly, every time we should reflect upon how better care can be given to this particular set of patient when they come to us. So I would conclude with the say that human behavior is messy and unpredictable, and unconcerned with convenient symmetries. Again, I would like to emphasize that inclusive culture of patient as such, we are not judging our patients, but the with the background they present, it always affects. According to the regional practices, it may affect the treatment, which we need to nullify and show the highest professional behavior. Thank you so much, and I'm really sorry for the technical issues we had during the presentation. Over to you, Sree Sowjanya.
That's a wonderful presentation, Dr. Sapna. You have covered almost everything that is required for behavioral emergencies. I'm just seeing if there are any questions. We don't have any questions. So what is your experience in dealing with acute psychosis patients in the emergency department? So in the sense that, do we need to have any extra resources for these people? Are there any specified resources required in the emergency department to deal with acutely agitated or acutely psychotic patients?
Yeah, so this patients, as I said, when acute psychosis patient presents, and if he is not interested in leaving, the suicidal attempt by agitated patient present pose threat to the our environment, particularly when our suppose my ER is 12 bedded, and there is a one patient in ER who is making this type of who is presenting with this, then it affects the whole environment. If it is an open ED, it affects the whole environment of emergency department, all residents, all doctors, because they will drain your attention, plus they will use more manpower. So we need to have an isolated area, we need more staff, we need to sedate them with the temporary or short acting sedatives. Till the evaluation, we have to restrain them, but the restraint should be such that they should not add further damage. And then you may have to allow the relatives. Usually we don't allow relatives, but in such patient, to build their confidence, we may have to allow relatives with them to help in restraining them or making them to cooperate with the treatment. And usually in the large institute, big institutes like in mine, we have a medical legal center right in front of our hospital, police station, notifying officer, everything is right there. So we can bring all of them in the ER itself to finish the rest of the formalities, you know. So that should be kept in a mind.
Yeah, that's an excellent elaboration, Dr. Sapna. I have one more question to pose to you. So the biggest challenge an emergency physician faces is to differentiate between an acute psychosis patient versus a psychiatric emergency. So can you give any tips to our listeners about this?
Yeah, see, I actually have done 2-3 case series is publication on my name on this psychotropic drugs. One was of hyponatremia. There were 7 cases I elaborated. One had seizures. He presented, all patients presented with hyponatremia, and they were because of the as the extended side effect of the antipsychotic drugs, with the background of fever or episode of diarrhea, or that's what triggering event. Then there are newer antipsychotics which can do suicidal tendencies. So this patient, it might be confused that this patient inherently have a suicidal tendency, but that may be because of his chronic medication or some interaction with other psychotropic agent, like person taking a weed, or might be given weed, or this patient are prone, they are vulnerable population, they can get manipulated easily, and this can trigger a delirious or this episode. So key is to identify as an emergency physician, try to find things which can kill in within minutes or within hours, right? So we will always look for the quick fixes like hypoxia, hypovolemia, vital stabilization, with the wide range of diagnosis, intoxication to stroke to meningitis. You know that a big spectrum of diagnosis is to be done. We might have to over investigate these patients, but it is justified for this complex medical presentation. So
Yeah.
I would say, if patient present with headache, chronic headache, and comes with a severe throbbing headache, without hesitation, we should go for a CT brain and rule out any organic cause or a bleed in these patients.
Yeah. So that's a nice elaboration from your end. And I don't think we have any questions from the audience. So what was your experience to manage these patients in your 12-bedded ED? As you know, they consume a lot of resources, and we need a lot of infrastructure to them, which does not cause harm and isolate them from the rest of the crowd. So what was your experience in dealing with such emergencies? Is there any innovative things that you have done in your emergency department to share with all of us?
Yeah. So if I tell you a simple patient, there is a middle female, and she was complaining of abdominal pain continuously. Now she came without anyone, any family member.
Attendant.
She came alone to ED. Yeah, at any attendant, and she was staying in the ED. When I came for my round, I asked my resident, "Well, ma'am, she is a known case of psychiatric illness. She comes many times over here, and many times she goes, and right now she is not cooperating with the treatment." When I went to her, she started shouting, and she tells me that they are telling me that I am a mental illness patient, and I am having severe abdominal pain. So I ordered USG. I called a gastrophysician. Then we evaluated her drug history. She took almost 9 tablet of NSAIDs in last 36 hours. So obviously it is going to cause hyperacidity or gastric reflux or gastritis. Eventually she was taken for scopy, and she had a gastric ulcer, a drug-induced gastric ulcer. So this is one experience which I am able to recall right now. One, I had a female, 45 years old, and not 45, rather she was in 30s, and she was complaining of right-sided chest pain. I was working in a private institute at that time, and we know that we hospitalize all and keep them in observation. So 24 hours, she kept on we almost took 4 or 5 ECG. Each ECG was normal. On third day, she was also a very affluent patient. So she was capped in the special room for 3 days. On third day, she had a inferior wall MI. She had cath, and she had right PCA RCA stanting done. So all the previous ECGs were normal before this ECG, which was showing inferior wall edema. So that was actually an exceptional case, and she was lucky enough to be in the hospital after then she was receiving all sort of distilled water shots and MVI shots for her pain. So this is another experience, I would say. And of course, a violent patient, we get them many times, but they are as good as OP poisoning patients, and usually we can manage them well.
Yeah, during your session,
With
I
a
really
wide
like the phrase you mentioned. If the patient is complaining of chest pain for 5 times, don't worry, keep taking the chest pains. I think this is the example that you wanted to say to all of us. Many a
Yeah.
times, medical emergencies in psychiatric patients are missed because we initially itself label them as psychiatric patients, and the underlying medical problems sometimes are missed in the emergency room, and we should be vigilant for those things as well. So one more challenge what an
True.
emergency physician faces in dealing with these patients is sometimes in their acute psychotic phase, they are unwilling to take any medicines. They are very agitated. And how do we approach these patients who are conscious,
Yes.
violent, agitated, and not allowing you to give any sedation to them? Because there is a medical legal
And
implication as well.
yeah. Yes, so it becomes, and the situation becomes even more complicated when they come alone to the ED, or they are brought by the bystanders or from the no near relative. So according to institutional protocol in my hospital, the protocol is we inform the local authorities, our superintendent and RMOs, and we take the all rights of patient under us as an unknown patient, and we will inform the police station, we will do a medical legal notification, and then we will treat the patient as our own relative. That's
So
the policy in my hospital. And
yeah,
we will do the best, which is we will restrain, we will give sedation, and we'll proceed with the all safety measures and required investigations.
So we have to treat the patient with the best standards of care required for them at that point of time, even though in their psychotic phase, refusing for treatment and if there is no attender.
Yes.
Right?
Yeah. Yes, because in our country, yes, we don't have, in our country, we do not follow the willingness, autonomy in terms of when they are want to harm them. It is society is illegal, and even do not resuscitate is also with so many clause in our country. So it is always better to have a clear yes or no or clarity that what we are going to do rather than staying in dilemma. So I would always prefer to go with the first approach where we give all possible benefit of doubt and based of patient's future or his health.
So there's another challenge as emergency physicians we face is unavailability of a psychiatrist in the hospital, or some hospitals will not have psychiatric admission rights as well. So how do we approach patients in those conditions where a psychiatrist is not available, and psychiatrist ward again requires special permissions where they cannot harm themselves with the law, with no metal frames, all those things, right? No metal windows where they don't jump out of the windows. So a lot of guidelines are there for psychiatric ward. So many hospitals will not have a provision of a psychiatric ward or a full-time psychiatrist available in the hospital. So how do we approach such patients in the emergency room in the event that there is no in-house psychiatrist and a psychiatric ward?
So for that, guidelines are clear. If they have unstable hemodynamics or they have organic background comorbidity, like I saw, demonstrated in one slide that American Psychology Association has given some criteria that when they are anorexic, they are malnourished. In that condition, we need to endure this patient. About the psychiatrist, I'll tell you, whenever, even if the institute has got psychiatrist, And if we do psychiatric refer, in this condition, they are not going to, the usual advice will be withdraw all psychotropic drugs and rule out the organic cause. This will be the usual advice. So again, we have to go for usual ABC approach: airway, breathing, circulation, stabilization of vitals, and then the disposition is always with the consent of family and authorities to the appropriate mental rehabilitation center or to the ICUs with the proper isolation environments. So this is given in the guideline that we need to send them to rehabilitation or to the medical recovery center only, mental recovery centers. So that's what is written in the guideline.
Yeah, thank you so much, Dr. Sapna. To summarize, behavioral emergencies are very complex and pose challenge to us as emergency physicians. And definitely, we need to have a multidisciplinary approach for these patients involving required specialists. And most important is underlying medical emergencies should not be missed in the emergency room, even though they have a prior existing psychiatric illness. We have to consider that symptoms, and a symptomatic approach is the best way that we have to deal with these patients. Like in your example, a patient of acute abdominal pain or a patient of chest pain, leaving it out to be a gastritis or acute in myocardial infarction. So such things are very commonly missed in these psychiatric illnesses. Should not we should be very, very vigilant in the emergency room to address these problems as ER physicians. And most important, communication and empathy is very, very important for emergency physicians dealing with these patients. And thank you so much for an elaborative discussion and lecture from your side, and very, very insightful, and you brought us a lot of knowledge today in this webinar. Thank you so much.
Thank you so much, Dr. Sowjanya. I love the interaction and I wish it conveys the message which we want to convey to our PGs and our coming generations.
Yeah. Thank you so much.
Thank you.
Yeah.
Bye.